Hello. As we get started with today's presentation, we encourage you to complete the Project Implicit Weight Bias Association test published by Harvard University. The link will be put in the chat, or you can Google Harvard Implicit Bias Test. Welcome to today's simulation on team communication. The topic of today's simulation is weight bias. The objectives for today's simulation are shown on the screen. As a reminder, today is a low-stakes activity where your grade is based on your participation. This is a safe space meant for you to ask questions and share your knowledge with your teammates. As with most of our team-based simulations, this will be a 2-hour encounter. We are starting now with a slide deck review, so we're all on the same page moving into the case review. You'll then have 10 minutes to huddle with your team and plan your team-based patient interview. We'll then welcome our patient, where you will have 15 minutes to interact as a team with that patient. The remainder of the session will be spent receiving and giving feedback and debriefing the team experience. We'll start with a short introduction of our author. This presentation was created by OU Health social worker Emily Johnson. Emily coordinated a team of student leaders and faculty preceptors in the creation of this content. We thank the team for their hard work. We'll also note that this presentation is intended to address the effect of weight stigma and not a review of the disease processes or diagnoses. As Emily says, we're here to discuss the elephant in the room when it comes to team-based care of this patient population. Let's get started. What is weight stigma? I'll read the short definition shown on the screen. Weight stigma is a negative weight-related attitude and beliefs that manifest as stereotypes, rejection, prejudice, and discrimination toward individuals of a higher weight. This is also known as weight-based discrimination, and it's estimated that stigma has increased by 66% in the last 10 years alone. We'll take a moment to make sure we are all on the same page about what stigma really is. A stigma is something about you or another person that makes others devalue or disapprove of them. In this case, weight stigma is devaluing or disapproving of others solely because of the size of their body. We'll use stigma interchangeably, the term stigma, with the term bias. However, by definition, bias refers to the act of using our own opinions to make judgments against others. In our prerequisite psychology courses that we all took, we learned about explicit and implicit bias. Our biases toward others can be intentional or internal unconscious thoughts. Some biases are good and keep us safe, such as our unconscious bias against touching fire, which we all know is bad. We form these biases as part of our interactions with the outside world as our shortcuts, our mental shortcuts between knowing or perceiving what is good or bad. The concern here for our health team is that our biases, again, whether intentional or not, can lead to discriminatory actions against our patients or their caregivers. Here, discrimination is shown as the practice or act of treating someone based on their traits. This is, however, often based on our biases or stigmas against others for those traits. So we all have our biases, which means we all have stigmas, right? As it relates to weight stigma, it's important to note the finger is not only pointed at the healthcare community. This is a larger societal issue. Much of the stigma according to one's physical appearance, as we know, festers in our media and entertainment industry. We see it reinforced in marketing ads, in movies and TV, and on and on. We also know that otherness, or stigma against those that look different than us, is often used for political gain, yet sometimes with good intention, such as public health initiatives. Yet, this all can reinforce negative stigma and discrimination, again, simply due to physical characteristics. I'll now ask everyone to use the chat and respond to the following questions. What examples of weight bias or discrimination have you seen? Can you think of common ones in movies or maybe a personal situation that you witnessed? You can go ahead and type them in the chat. And I'll take a step further. Have you seen them in healthcare settings? So as everyone's typing their response in the chat, I'll read a few that are on the screen. One of the common comedic uses is the use of fat suits on actors. That's where a smaller actor wears a suit to make them look larger for the purpose of comedic relief. Others might be microaggressions, such as body language people use around those that are in larger bodies, like scooting aside or such. Or something that I have happen often to me are backhanded compliments, such as, "You're not that big," or "You have a pretty face for a curvy girl." I get that a lot. We'll move on, but I want to take a moment, you can do so, to read through the chat on your own and see each other's comments. Now that we've defined bias and stigma, we'll spend a moment discussing obesity. The Latin term obesus means to eat oneself fat. The World Health Organization, however, defines obesity as the abnormal or excessive fat accumulation that presents a health risk, usually requiring a BMI of 30 or higher. Emily, our author, adds the note here that many people in larger bodies do not like the term obese because the term itself is highly stigmatized. We use it in healthcare because of the clinical diagnosis and coding associated with obesity, but we acknowledge that it is a current term that is regarded with great bias. With regard to diagnosis codes, obesity is under ICD-10 E66 category, and per the ICD-10 definition, obesity occurs over time when you eat more calories than you use. The balance between calories in and calories out differs for each person, and factors that tip the balance include your genetic makeup, overeating, eating high foods, and not being physically active. We note here that morbid or severe obesity has its own unique code for billable hours. Unfortunately, the diagnosis codes fail to attribute the additional known factors of weight and therefore reinforces the learned bias and stigma against those in larger bodies. The cause is a blame factor placed on the person experiencing excessive weight gain because they consume too many calories. But there is truth of the impact of while there's truth of the impact of calories, it fails to acknowledge the additional contributors to health, such as social determinants of health, our global food systems, access to food, race, epigenetics, or economic status. By forming conclusions on partial information, we are reinforcing the stigma associated with real health concerns. Briefly, we'll review our experience with obesity and what has led us to this point. Although obesity is seen in various cultures across the ages, sometimes associated in ancient times with motherhood, for example, we'll start today's local discussion in the mid-19th century. The first published cure for obesity was listed in 1869. The first bypass weight loss surgery was performed in 1880. And with the changes in agricultural and industrial economies, we saw changes in physical activity and access to food. We began to see obesity increase as a mark of the common poor man, or sometimes conversely, with the rich folks that had opportunities for more food. In this time period, we also saw an increase of the use of weight for comedic purposes, but also the growth of religious discrimination against those that were overweight. The 20th century was where we began to see the health community start taking note of weight as a medical concern. We also saw the growth of the weight loss industry. You can think of Weight Watchers or Jenny Craig, or today we have Noom. Also in the 20th century, we saw government start to get more involved with public health approaches, such as the food pyramid, that triangle that taught me that bread was good for me. Or today we have the My Plate approach. Emily included here some of the media that was used during that time. Before we had My 600-Pound Life, those who were overweight were even considered sideshow attractions in the circus. So you can review some of the ads that are shown here. As we fast forward to the mid-1990s, we officially see the World Health Organization define obesity as a concern. Here, they listed BMI as the international marker for obesity, and by 1998, obesity is listed as a disease and an epidemic. Interestingly enough, at that same time, the standard classification for obesity was actually reduced from 27 to 25, which automatically shifted many Americans into the overweight diagnosis level. Also, interestingly enough, in 2013, the American Medical Association classified obesity as a disease, even after its own research committee found no specific symptoms associated with it, and warned that BMI alone could lead to unnecessary or costly treatments to those who are otherwise healthy. And today we have our current situation where we still have the fight against obesity, the fight against childhood obesity, and social and governmental campaigns against weight. We'll now review BMI a little further since that's the root of our obesity definition. We saw the World Health Organization adopt BMI as its sole measurement for diagnosing obesity in 1995. But what is BMI and where did it come from? In 1832, over 150 years before the World Health Organization adopted the BMI, it was created by a Belgian mathematician in his research on Swedish men. His work looked at the average man in Sweden to determine the average weight, height, and fat percentage. Again, this was just among Caucasian Swedish men. While there is room for debate, it is often questioned why the World Health Organization, 150 years later, would use a mathematical calculation created for Swedish men's body types to diagnose humans around the planet with a disease. The controversy and ongoing questioning is inflamed by the fact that the World Health Organization took millions of dollars in donations from pharmaceutical companies. While weight loss drugs can be life-changing or sometimes life-saving for our patients, we all understand the ethical dilemmas in allowing profit-driven companies to guide health standards and treatments of care. We know a lot better now, 30 some odd years later. But we also must be mindful, as stated in the literature, whether intentional or not, our tradition of finding characteristics of marginalized communities and labeling those characteristics as bad or as a disease are common in the tradition of healthcare. It is important to note where BMI has also been used in other areas. Even though Ketele himself said that BMI calculation was only accurate about half the time. In his index, the BMI was used to justify eugenics. Eugenics is the discredited belief that we can remove undesirable traits through selective breeding. The result, long studied as being scientific racism, was the mass sterilization of those with otherness, whether it be people of other colors, nationalities, disabilities, or those with other financial holdings. Lombroso went on to adopt Ketele's work to justify defining people of color as an actual separate species they referred to as Homo criminalis, meaning the criminal man. Outside of research, we also found life insurance companies adopting the scale, the BMI, and deciding how much to charge or whether to even insure certain individuals. It's a bit shocking that our healthcare community has made such a jump to adopt a scale used for one specific patient population as the sole determining factor for a diagnosable disease across the planet, even though the original author demonstrated it was not accurate even the majority of the time. Yet, as it remains, BMI is still used today and considered the appropriate screening tool. You can jot down the scale for use in the patient encounter if you like, and there's also apps for your phone. But today our BMI range for a healthy adult is considered 18 to 25, and those with BMI over 30 are considered obese. And then there's even additional ranges for those that are considered obese. This graphic demonstrates that same scale in just a different way. Here we see those with BMI over 35 listed as extremely obese. BMI in the literature indicates that body fat can be used to predict diseases such as heart disease, hypertension, pregnancy complications, and mental health disorders. Noteworthy here is the common lack of diagnosis for those with underweight BMI calculations. Studies show BMI is most commonly diagnosed in those who are overweight rather than those who are actually underweight, even for those with other symptoms of eating disorders. In treatment planning, we find BMI also used to recommend interventions for those with BMI over 30, including weight loss surgery. Even in pediatric treatment, those aged 3 and over can be treated with behavior therapy based solely on BMI. And at age 12, you can be treated with pharmacotherapy or even surgery based on BMI. Emily has us take a pause here. Using her own life experience, she notes that at age 12, she was 214 pounds and had a height of 5'8". Her BMI was 32.5 and qualified her at 12 for prescription weight loss drugs or even weight loss surgery at 12. Let's acknowledge a few of the other limitations of the BMI. It was not intended to measure women, children, or anyone living outside of Sweden, and certainly not anyone living outside of Europe. 2, it does not take into factor any other physical or medical presentation. 3, epidemiological research, even though BMI has correlation to health issues, it also shows an association with longer survival rates. And 4, studies show no significant increased all-cause mortality risk correlated with BMI, meaning there's no connection between risk of death and BMI. We also need to point out the limitations related to cardiovascular disease, CVD. Studies actually show that those who have an obese BMI have a better prognosis for cardiovascular disease. This is known as the obesity paradox, where those with lower weight actually have poorer outcomes. And CVD is just one disease process. Much research is being done to find root cause analysis factors and correlating those to health outcomes. However, we must question the limitation of BMI in making those determinations. Now we'll transition into discussion of provider bias and the weight of bias on our healthcare environment. This is because it is believed that mortality risk actually increases almost 60% for those experiencing weight bias from their providers. Why is that? Let's get into it. Starting with healthcare education, we'll pick on medical students a little bit, although that's a bit unfair. This is just where the published literature is today. I'm sure we'll have more in the near future about other professions. But here Emily included a few studies where you can see the hyperlinks in the slide deck if you wish. It's in Canvas. And these studies showed that the majority of students had explicit bias toward obese patients. And the majority of students believe obesity is caused by ignorance. And unfortunately, our average four-year medical school curriculums across the country spend only an average of 10 hours on weight-based education. Further, our health sciences education methods continue to teach that BMI is a causation of disease rather than a correlation. This is seen in the preference for weight loss treatments and our current systematic issues of weight cycling or yo-yo dieting. Into practice, we then see documentation that providers spend less time with patients in larger bodies and perform less physical exams. We see studies where half of providers label obese patients as non-compliant. And a quarter of nurses report that they are repulsed by obese patients, and up to 45% say they would prefer to not even take care of them. Studies show that providers are more likely to prescribe weight loss rather than consider medical interventions to treat or manage other diagnoses. And we still see the stigma of physicians treating their patients as less adherent or less motivated. So what happens when we put the patient in this mix? So our students enter health sciences education with their preconceived biases. Again, we all have them, good or bad. We all have biases. And then we reinforce those negative biases with the medical education that we provide. And according to more modern studies, we incorrectly associate BMI with disease causation rather than correlation. And then we enter our provider environment where we are also ripe with stigma, such as shorter patient encounters or preponderance to prescribe weight loss over other medical interventions. And so here enters our patient. The patient encounters the provider who may have those stigmas, and that affects that provider's clinical decision making. The patient encounters the healthcare environment where there are environmental cues such as narrow waiting room chairs or gowns that are too small. The results seen in the literature often include the patient being reluctant to seek care, avoiding healthcare in general, or the patient may not trust their provider or their recommendations, and of course, poor communication due to lack of trust and respect, all of which impacts the patient's health outcomes. It's estimated that 72% of patients, a large majority, report being impacted by weight stigma. The impact is documented time and time again in the literature. Patients experiencing weight bias are less likely to adhere to recommendations, more likely to avoid seeing the same clinic or provider, and will often delay care. We also see impacts on misdiagnoses. This is shown in the literature in numerous facets. First, we have false negatives, where diagnoses are missed because the patient's weight is attributed as the diagnosis. Second, we see that patients are not given the same routine tests that can assist in the diagnosis process. And last, as we discussed earlier, we see a 60% increase in mortality risk among those experiencing weight discrimination when controlled for other risk factors. And again, controlling for other risk factors, those experiencing weight stigma are also seen to have physiological effects such as elevated blood pressure, mental health concerns, and an increased risk for diabetes, again, controlled for that stigma. We'll take a moment here to also discuss weight cycling, also referred to as yo-yo dieting. This is where someone tries a weight loss intervention, loses weight, then regains the weight after that intervention is discontinued. When the intervention is something like a fad diet, this can happen rapidly and it can be cyclical. What we find is a significantly higher correlation, but again, not a causation per se, to higher mortality rates, hypertension, gallbladder issues, and even some types of cancer. This diagram outlines the impact of weight stigma on behavior, physical health, interactions with the healthcare system, and stress and negative effects on the patient. Again, you can see that this can be cyclical, and you could think of this cycle as this. I'll give an example. So you are not feeling well. You are fatigued and experiencing headaches. You start gaining a little bit of weight. You seek out medical attention for the headaches and fatigue. Your provider thinks that you'll feel better if you lose 5 to 10 pounds and doesn't think you need to do anything just yet for the headaches and fatigue if you add daily 30-minute walks to your routine. They also recommend intermittent fasting for your age group. You try that for a week and you lose 4 pounds. That's great, right? But then you gain the weight back over the next few weeks, and actually you gain back a few extra pounds. All the while, you still don't feel well and you're still having those headaches. Now you also have lower self-esteem because you failed to keep off the weight, and your stress response is activated, and you see an increase in your blood pressure, and you still don't feel well. So the question is, do you go back to the same doctor that didn't listen to you the first time? This diagram outlines the cycle in a slightly different way. On the left, you see the weight-centric approach, where the doctor focused on weight instead of the headaches. On the right, we have the weight-neutral approach. This is where a provider would focus on the headaches and maybe also recommend an increase in physical fitness. This will be our approach for the remainder of the lecture. Here's another example of the difference we see in weight-centric or weight-neutral treatments. The quote at the bottom is from a physician who shows where they have noted patients in dire emergent situations following misdiagnosis from a weight-centric approach. And this is it's not just cartoons, right? This is real life. There are documented cases time and time again where severe medical issues are missed due to weight diagnoses. On the screen here, you see Rebecca had cancer, Hannah had an ovarian tumor, and Ellen died 5 days after because of her misdiagnosis. And this is Miss Ellen, where in her obituary, her family shared about the fat shaming she endured from the healthcare community. She felt unwell, she sought out help, and was told to lose weight. And her dying wish was to advocate for others to see health beyond their weight. So where do we go from here? We know that we all have biases. We know that stigma can affect treatments. We know that weight cycling can have negative effects, and we know that weight-centric approaches can lead to misdiagnosis. The recommendation that we'll practice shortly in our patient encounter is the weight-neutral approach. This means that we look at the patient's health independent of their weight. BMI is no longer used, it's not used to diagnose the patient, and is not solely the only diagnosis for the patient. And when weight loss is not achieved, the blame is put on the weight loss technique or intervention, not on the person. The Association for Size Diversity and Health has put forward the recommendation shown on the screen for health at every size. We'll get into each of these a little bit further. Their recommendations for health at every size includes 1, weight inclusivity. This is being inclusive of patients of all sizes and shapes and being mindful of that. And then 2, life-enhancing movements. This is where providers can support physical movement rather than focusing on calorie-out exercise approaches. Additional recommendations include eating for well-being, which is promoting eating for well-being rather than the calories-in dieting approaches. And then 2, practicing respectful care. We also want to acknowledge that we have our biases, but that we want to provide that respectful care to our patients. And then last, the recommendations for health at every size include focusing on health enhancement, where we support access to whole person wellness. Another method to focus on body neutrality, not just body positivity, is where we can help our patients to not just love the body they're in, but first learn to love their body. The health at every size approach has good results. Again, Emily has articles linked here in the slides if you want to read them further. But the method has shown improved physical markers, healthy activities, and improved self-esteem. And the focus on healthy movement rather than weight loss programs is shown to reduce mortality risk. It's shown to lower cholesterol and reduce blood pressure. We'll wrap up this with this final study on girls participating in the Body Project. The Health at Every Size group of this adolescent control study, they sustained their health improvements, whereas the dieting control group regained their weight and did not sustain their health improvements. So again, yet another study showing positive outcomes with the Health at Every Size program. Okay, we'll wrap up our last section with discussing methods for weight neutral approaches or methods to address our weight biases in practice. So first, from an ethical standpoint, all professions swear their respective oaths to do no harm. This chart provides examples of where ethical approaches to care impact policy and actions with clear examples for practice. You can save this from the slide deck if you wish. This may be another chart that you wish to screen grab. This has tips for healthcare team members that can be incorporated into practice. I won't read them all to you, but a few key items are asking your patient if they would like to talk about their weight and acknowledging that you ask all patients the same question. So again, I ask all questions. Would you like to talk about your weight today? Another point is ensuring that your facility where you work has supplies and equipments for patients and clients of all sizes. So again, if you offer gowns to a patient, make sure you have gowns for all sizes. And then last I'll mention here, do not praise weight loss in itself. So unless it's part of the conversation, you don't want to walk in and say, hey, you've lost weight, I'm proud of you. You want to focus on the health and other markers instead of the weight on the scale. A few additional tips include holding your team members accountable if you hear discrimination occurring. And this should go for any discrimination, not just weight bias, but be empowered to hold others on your team accountable. And then also redirect focus on health and well-being rather than weight and size. So if your patient is discussing or other team members are discussing weight and size, always feel empowered to redirect that conversation to health concerns. Okay, we have additional practice tips here. We want to encourage our team members to acknowledge that weight bias and stigma are actually decreasing the health of our patients and clients. We encourage you to speak up on behalf of your patients when other providers may not be addressing the patient correctly. So if you see something, say something. Another tip is to remember that language matters. And so you can download this whole document at the link, but today we want you to practice making these changes in your language. Instead of saying fat, we'd like you to say weight. And instead of saying obese, say unhealthy weight. And it's okay to make a mistake, especially today. We want you to help listen if others do it as well. So remember, we all have our unconsciouses working against us. We may not even know we say it until we do it or unless others pay attention. So today, let's practice using weight and unhealthy weight in our discussions. In cases where the patient does want to discuss their weight, or perhaps due to a health indication other than BMI, it may be medically necessary to discuss weight, we encourage you to use motivational interviewing techniques. Today, you can practice these techniques during the patient encounter. Key points include using emphatic listening and watching your body language and verbal cues. So all those things we talk about making eye contact, nodding, etc. You can also point out if the patient's goals are not aligned with their current health behaviors to achieve those goals. And we want you to remain optimistic and provide the patient with confidence that they can make meaningful change and that you are a resource for them. As we wrap up this presentation, we must point out the intersectionality of bias and health. Weight bias is rarely independent of other biases, just as weight is rarely the only identity of your patient. So please consider where ethnicity, gender, disability, or other factors such as social determinants of health interface or may contribute to bias or the experience of your patient. The feeling of otherness among our patient population is a known challenge. The otherness of weight is not alone in the patient experience. Thank you for reviewing this content. Emily and our whole team welcome your thoughts and your feedback. You will also have an evaluation at the end of this activity. So please do help us make this presentation better for future students, and you can reach out to Emily at any time. Now I'll turn it over to your Zoom coordinator who will start the case review and team huddle and get you ready for that patient encounter. Thank you.